Welcome to AETCM, the emergency medicine channel. So nowadays we started with an respiratory emergencies. In part 1 we discussed the respiratory system assessment. Part 2 we discussed the upper airway obstruction. Being a part 3 we'll discuss the lower airway obstruction. Mainly what are the common conditions that will occur in lower airway obstruction, how we have to assess and then how we have to manage it more specifically in the pre-hospital scenario. Those are the things we'll discuss one by one. First thing, so obstructive lower airway disease, these are the things have a characteristics of diffuse obstruction of the airflow within the lungs. This is the most important term. It will cause the diffuse obstruction of the airflow within the lungs. What it denotes means, and then we have to think the anatomy. So how the airway will form. So first we have a trachea and then it divide into the right and left main bronchus or stem bronchus. From that it have a lobar bronchus, means so right lung we have a 3 lobes, so each lobe will get a 1 lobar bronchi, and then from that you have a segmental. Again segmental furtherly divide into subsegmental, and then it will still it will go to the terminal bronchus to the respiratory bronchus to the finally alveolar duct and then alveolus. This is the way our anatomy. So first it will start from the trachea and then it will divide into right and left bronchus, and then it will goes into the lobar bronchus, and then it will go to the segmental and subsegmental bronchus. Again it will go into the respiratory bronchus, finally alveolar duct and then alveolus. If any obstruction in the sense any edematous, otherwise any foreign body obstruction, that will happen in the either it in main stem bronchus or either it occurs in the any terminal bronchus, means the whole lobe get affected. So that diffuse in the sense the whole lobe, that overall area will get affected. That's why it will cause the diffuse obstruction. Again lower airway in the sense below the glottic opening is the lower airway, above the glottic opening is the upper airway. So it will cause the diffuse obstruction of the airflow. What are the common conditions that will we have in lower airway obstruction means chronic bronchitis and emphysema. So collectively we known as a COPD or COLD, chronic obstructive pulmonary disease or chronic obstructive lung disease, whichever way we can call. And then third condition or second condition is a bronchial asthma. So chronic bronchitis, emphysema collectively called as a chronic obstructive pulmonary disease, and then second condition is a bronchial asthma. So we'll see one by one. First one is a bronchial asthma. What is mean by bronchial asthma? Asthma is a chronic inflammatory disorder that characterized by the increased responsiveness of the airway to the multiple stimuli. Increased responsiveness, otherwise you can remember as a hyperreactivity of the airway. What it denotes means hyperreactivity. So think the normal physiology. If any dust particles or foreign materials that reaches your airway, means what will happen? Simply we will sneeze or simply we will cough it out. So the main goal is to expel the foreign body or dust. That is the normal reaction. But in the case of asthma, what will happen means the reaction will get a hyper state. So there will be an increased mucus production, there will be an increased everything in a hyperactivity, that is called the asthma. So hyperreactivity or increased responsiveness of the airway with a multiple stimulus. Second thing, status asthmaticus, it is a medical emergency cases. Medical emergency, it is a more severe and prolonged asthmatic attack that can't be stopped with a conventional treatment. So usually in asthma cases, we'll give some medication or nebulization that will reverse the bronchoconstriction or bronchial edema, that will reverse. But in status asthmatic cases, that won't occur like that. It needs some aggressive management, that is called status asthmaticus. So what are the things? Usually what's the pathology will occur in the asthma? First thing, these are the triggers like exercise, cold air, emotional stress, occupational exposure, beta blockers, that is most important, viral acute respiratory infection that leads to the hyperreactivity, result in the widespread reversible narrowing of the airway. This is most important, reversible narrowing of the airways or bronchospasm. Narrowing means that is called bronchospasm, narrowing of the airway, and then it will cause the inflammation. So inflammation, so we know that what are the 5 signs will happen in inflammation means rubor, collar, dollar, tumor, and then loss of function. So that is the inflammation. So here it is happening the tumor means tumor in the sense bronchial edema, increased mucus production. That is the inflammation. So we have to understand the three major main pathology here. First one is a bronchospasm or reversible narrowing of the airway. Second one is the inflammation. In inflammation, you will get a bronchial edema. Third one is a increased mucus production. This is the common pathology that will occur in the asthma. That is most important. And then because of, so by the way, what you will get, this is the bronchus means, so bronchospasm will occur. Bronchospasm and bronchial edema both are different term, both are not same term. We'll see the next slide. So bronchial edema and then bronchospasm will occur, mean the same time, increased mucus production. So these are the things ultimately leads to the narrowing of the lumen, okay. It will affect the diameter of the bronchus, lumen, inner lumen. So this is the first one. Second pathology is because of positive pressure exhalation, it will cause the small airways to pinch set. Means, I think the normal physiology, in inhalation, how we are inhaling, so our pleural cavity went into the negative pressure to more negative pressure. By the way, your atmospheric air will get enter into the lung, and then it is the inspiration part. But in the time of exhalation, how it will occur? So the pressure will increase, that will become a positive pressure. By the way, it will expel or exhalation will occur. So here positive airway pressure that leads to one shutting of the, that will close the, that otherwise that will pinch the smaller airways. Smaller airway means terminal bronchioles, your respiratory bronchioles, those are the smaller airways. So ultimately, already we have a narrow lumen, mean the same times we have a airway, that pinch out of the airway. These are the things leads to the trapping of gas in the alveoli. So this is the major pathophysiology that will occur in the asthma. So main thing we have to keep in mind is a bronchospasm, bronchial edema, and then increased mucus production. So what is meant by bronchospasm and bronchial edema? So bronchospasm, spasm in the sense easily we know that will occurs in the muscle only. So muscle spasm like that. So the same concept only we are applying. So bronchospasm in the sense there will be a muscle spasm in the bronchus smooth muscles. That is the thing. So with the bronchospasm, the muscle get contract, the smooth muscle of the bronchus get contract, that causing the entire tube to narrow. So it will causing the entire tube. So it mainly it focusing on the outer region, so smooth muscle region. But in the case of edema, what will happen means the wall of the tube gets swells, causing the lumen to narrow. Means here it concentrating on the outside of the bronchus. Here it concentrating in inner the lumen. So inside of the wall, that will form the edema, that will form the swelling. Thereby the lumen get narrow. So both are different. So it will concentrating on the muscle, smooth muscle of the bronchus. It will concentrating on the inner lumen part. That is both are different term. And then incidence wise, so the fastest growing asthma rate, that is at children's younger than 5 years, death rate wise higher in people younger than 35 years. It is more common in men, but severity wise more severe in the women. So fatality wise, when the death will occur means severely compromised ventilation, not following the regular medication, severe psychotic disorder. That is some incidences just for the sake of knowledge. So assessment wise, assessment and management, we have to follow our proper or scheduled, what are the things, our fixed emergency protocol we have. So we'll start up with the scene size up, and then we have to go with an the initial 10-second assessment. That is the thing we have to follow. So here we mention like what are the focused thing, otherwise what are the major important thing that will occur in the asthma that we are going to see. So first one, assessment wise, the first assessment and management. First for important step is we have to try to identify the trigger. So without identify the trigger, whichever medicine you can give, whichever aggressively you can treat, that won't reverse. So that is the most important. Otherwise, second step, you have to check the he or she have a fever or any rigors, is the patient coughing up or colored sputum, that and all we have to assess. Second thing, inspection part wise, we have to assess the prominent use of the accessory muscle of breathing. So we know for inhalation we can put up the collar, here you can see the sternocleidomastoid. For abdominal muscle you can assess for the exhalation, that is the accessory muscle. Hyperinflated chest means already we know that is the barrel chest appearance. Transverse diameter of the chest and then anteroposterior diameter of the chest is equal in ratio. Anteroposterior and then transverse diameter of the chest is equal in ratio, that is called the barrel chest or hyperinflated chest. Patient will usually exhausted because of the increased respiration, increased work of breathing, they will looks like exhausted, and then severe asymptotic. Asymptotic in the sense here it is related with an respiratory. So respiratory means here respiratory acidosis will occur because increased carbon dioxide buildup, hypercapnia state. So respiratory acidosis if you are applying means here you will get the rapid and then irregular breathing you will get, and then headache will be there. The person may look like a drowsy, and then some CO2 narcosis related things and all. Here we can see in the acidotic status. And then the person usually will be dehydrated status. Dehydrated, how we can assess? Simply we can see the oral mucosa, tongue, by assessing the tongue and then oral mucosa we can understand the dehydration. Auscultation point of view, if the airway is severely affected means there you won't get any breath sound or wheezing sound. Severe compromise in of airway means there you won't get any breath sound and wheeze. If mildly compromised means we can see the diffused wheezing and all we can see. So management wise, scene size of, we have to form a generalized impression, otherwise initial 10-second assessment, we have to assess the mental status AVPU, we have to assess and treat the life-threatening causes, airway, breathing, circulation, disability, exposure. That is a constant one. So more what is the point we have to focusing in the asthma means, so if you remember the pathology easily we can treat. So 3 pathology we told. First is a bronchial edema, second is an bronchospasm, third is an increased mucus production. This is the major pathology that occurring in the asthma. So by this we are going to manage. First one, it is a bronchospasm, means muscle contraction. That is a muscle contraction. So what we can give, we have to dilate the bronchus. So so there is a contraction. So we have to release the contraction. That way we are giving the bronchodilator. And so normally we have these in respiratory emergency. So mainly we are managing with a nebulization. That is the easiest route that we have a more effective than the IV and then oral, whichever route. So we are focusing on the bronchodilator, nebulized bronchodilator. We have a drug. So here we have a drug like a SABA. SABA in the sense short acting beta agonist, more specifically beta 2 agonist, short acting beta 2 agonist. So here we have a drug like a salbutamol and terbutaline. Salbutamol otherwise known as asthalin. Asthalin also we can call. So salbutamol and the terbutaline, it's a common drug. So side effect also we have to, most important, we have to know about it. So it will cause the nervousness, anxiety, insomnia, headache, hyperglycemia, palpitation, tachycardia, hypertension, and then skeletal muscle tremors. So here the tachycardia is most important. So if you started with a nebulization, within a 5 or 10 minutes, the person progressively they will develop the tachycardia. So that we have to note it down. So why tachycardia happening means, so the reason being the tachycardia, so we told it's a beta 2 agonist. Otherwise, it will act on the beta 2 receptor. So where is the beta 2 receptor? So we have a one heart. So that is there in heart we have a beta 1 receptor. Simply you can remember that we have a one heart. So the beta 1 receptor present in the heart. So we have a 2 lungs. So thereby the beta 2 receptor present in the lungs. So one heart, so beta 1 receptor in heart, and then we have a 2 lungs. So beta 2 receptor present in the lungs. So here you are giving the salbutamol, that is the beta agonist. So it will majorly act on the beta 2 receptor. Mean the same time it will have a minimal effect on the beta 1 receptor also. So thereby, if it will act in the, if the key will attach with an beta 1 receptor, means what will happen means it will increase the force of contraction of the heart, thereby it will increase the rate also. That is the reason for the tachycardia. So anxiety, hypertension, skeletal muscle tremor, those are the some common side effects. Second is a bronchial edema. So we told about the bronchial edema because of the inflammation. So we have to treat with an corticosteroids, that is an anti-inflammatory drug. So unlike a bronchodilator, the corticosteroids can improve breathing immediately. Why? So here bronchospasm that we told, it will happening in the outside because of the muscle contraction. Bronchial edema that will mainly that will occur in the inner wall of the bronchus, means that will cause the inner lumen to narrow because of the swelling. So while if you are giving a bronchodilator, means that will dilate the bronchus, but the inner lumen, that narrowing lumen will still remains because of the edema. But if you are giving a corticosteroid, means thereby you will decreasing the inflammation. So thereby the edema will decrease, the lumen will regain that same position, same circumference or same diameter, it will revert back. That is the major important thing. So the drugs wise, we have a beta-methasone, beclomethasone, and then we have a drug of ipratropium bromide also, one of the drug we have. So here the side effect wise, dry mouth, tachycardia, restlessness, irritability, confusion, difficulty in micturition, paralyticus ileus, blurring of vision, increase in intraocular pressure. These are the some common side effects. Third drug is mucolytic agents, because of here we have a increased mucus protection, that is a thick mucus. So we have to break the thick mucus and then we have to reduce the mucus protection. Therefore that we are giving the N-acetylcysteine, NAC or Bronac will call. So it is a 20% solution. Usually it will come in the 2 ml ampule. So we'll take 2 ml ampule plus 8 ml NS normal saline, and then in this dilution we'll take the 2 or 3 ml, 2 or 2.5 ml, will give a nebulization. So mucus, this Pronac and all, mostly we won't use in the pre-hospital scenario. Mainly these are the things will focusing on the definitive care, otherwise in hospital scenario we are using. Just the sake of knowledge we can remember. So mucolytics, this NAC. Mainly we are using the bronchodilator, that is a salbutamol, and then you will use the that anti-inflammatory, that is the common drug we are using. So another important thing, so nowadays we have some combination form also, because that is a name like a diolin. So diolin have a, dio means two drugs, so it's a combination of two drugs, one is salbutamol and then ipratropium bromide, that also we can use. So no need to use the separate form. So diolin is one brand, there we have a salbutamol and then ipratropium bromide with the same combination. So with the one respule it have around 2 to 2.5 ml. So simply we can use that one also. So again MgSO4, this is also in hospital scenario we are using. In the management of acute very severe asthma cases, we are using the magnesium sulfate. It is a route of IV route we are giving. So commonly it will come in the 2 ml ampule, it will come. So it will come with the 2 ml ampule, each ml contains 500 mg per ml. Okay, so usual dose is 1 to 2 grams IV over the 30 minutes. Nebulized magnesium sulfate also, it is effective, but it should be given once after the aggressive beta agonist and then corticosteroid therapy. So once if you treated with an beta agonist and then corticosteroid, still the person in asthma, there is still the person in distress, means that is the case only we are going with a magnesium sulfate. So here it will cause the, mainly it will cause the hypotension, and then it will diminish your deep tendon reflex. So that is most important. So while giving a magnesium sulfate, always you have to monitor the blood pressure, and then deep tendon reflex also we have to continuously monitor. And then next is a ketamine. Ketamine that inhibits the reuptake of noradrenaline and increase the circulating catecholamines, aiding some severe acute asthma. So noradrenaline and then adrenaline, we know it is a sympathomimetic drug. Sympathomimetic in the sense it will act along with a sympathetic system, thereby it will increase the heart rate and then increase the force of contraction, and it will dilate the bronchus. So that is the main action of the sympathomimetic. So if you are giving ketamine means that will inhibit the reabsorption of the noradrenaline, thereby the circulating noradrenaline level will increase. So it will increase the sympathomimetic activity, thereby it will increase the bronchodilation. That is the main thing. So here we are giving the IV bolus dose. It's about the 0.15 milligram per kg. If we want infusion, still the person in distress means we can go with 0.25 mg per kg per hour. Infusion also we can go up. So next is the epinephrine. So now only we told is epinephrine or adrenaline, it have action of sympathomimetic action. So here mainly we are using sympathomimetic epinephrine in the anaphylactic asthma. So in severe anaphylactic asthma cases, we are using the epinephrine. The route is most important. We are giving with a subcutaneous or intramuscular route. So the dose they mention like a 0.5 mg we are giving. So 0.5 mg, that is okay. Then other important question is where we have to give. So which area of subcutaneous or which area of intramuscular we have to choose. Here you think it is the thigh means here you have to choose the mid third and anterior part, lateral part. Anterolateral mid third of the thigh. So anterolateral mid third of the thigh. Here you will get a muscle of vastus lateralis. Vastus lateralis. There we have to inject the 0.5 mg of adrenaline. That is important. So here mainly we are using in the anaphylactic asthma, and then other form nebulization also we are giving. In the case of severe acute asthma cases also we are using the nebulization of epinephrine. So those are the some common medication. Mainly we are in pre-hospital scenario we will use the with the time shake we will use the anti-inflammatory, and then we will use the bronchospasm for bronchodilator only. So as like I told, Deolin it's one of the drug we are using in the continuously, that will the combination of drug of ipratropium bromide and then salbutamol. So second condition is a chronic obstructive pulmonary disease. Here each word denotes the separate meaning. So each and every word is the most important. First, it's a chronic. Chronic in the sense the condition will persist more than 1 year, that need a continuous medical attention. It is the definition for the chronic. So obstructive disease means that will obstructive disease in the sense that is a chronic bronchitis. Obstruction means airway obstruction, that is a condition of chronic bronchitis. Pulmonary disease in the sense that will have a disease in the parenchyma of the pulmonary, parenchyma of the lung, means here we are denoting the chronic emphysema. So chronic we told there is a condition persists more than 1 year and then that requires the continuous medical attention. Obstructive disease means that is the obstruction in the airway, that is the disease of chronic bronchitis. Pulmonary disease in the sense that is the disease in the pulmonary parenchyma, lung parenchyma, that is the condition of chronic emphysema. The other important things, COPD not fully reversible condition. You can treat with a lot of things, but it won't reverse, irreversible condition, but asthma is a reversible condition. That is one important thing. So pathophysiology wise, first one is a chronic bronchitis, means it is the obstructive condition, obstructive disease. So first one, chronic bronchitis. So itis, we know itis in the sense inflammation. So here inflammation of the bronchus in chronic condition. So in a chronic time interval is a chronic time, there will be a inflammation of the bronchus. So again inflammation in the sense the same formula you have to apply, Ruber, Kahler, Dollar, tumor, and then loss of function. So the same thing only. So inflammation of the bronchus in the chronic time interval. So chronic in the sense this, it is the term for the chronic bronchitis. So chronic bronchitis means sputum production in most days of the month. So most days of the month for 3 or more months. So for 3 or more months out of the year. So here out of the year for more than 2 years. I think it's still more confusing, but easy only if you read slowly. So most of the days, the sputum production will be there in most of the days of the month. Most days of the month, most days of the month for the 3 or more months in a year. Okay. So it will happen for the more than 2 years. So that is the term for the chronic bronchitis. In chronic bronchitis, hypercapnia and then hypoxemia is the most common one. If you take the ABG, there easily you can identify the increased PCO2 level and then hypoxemia, decreased SO2 or PO2 level. SO2 indicates the saturation. So PO2, partial pressure of oxygen, also will reduce in state. This is the two entity that will present in the chronic bronchitis. The other important thing is that the chronic bronchitis also called as a blue bloaters. So what is mean by blue bloaters? Blue indicates the discoloration. So that indicates the discoloration of the skin. Blue means cyanosis. So again the other important questions, why and when? Why and when? So cyanosis, when it will occur, and then why the cyanosis occurring. So what is the reason for the cyanosis? What the cause for the cyanosis? So when last part we answered like cyanosis will occur when the deoxygenated hemoglobin level reaches more than 5 grams per deciliter, means automatically that the bluish discoloration will occur. So more than 5 grams per deciliter of deoxygenated hemoglobin. That is the answer for the when. So why? What is the reason for that? Why the cause for the cyanosis? Mainly it's occurring the cyanosis in early stages, that will occur in the nail bed and then your oral mucosa. That is the common initial stage it will occur. Why means because of the shunting effect from the non-vital to the vital organ. Means, so in the case of hypoperfusion or in the case of hypoxia cases, there will be a naturally there will form a one shunting. So the connection between the non-vital organ to the vital organ. Non-vital, here we are mentioning like a nail bed, oral mucosa. Vital organ means automatically it will divert the blood to the non-vital portion to the vital, means we know the heart and brain and then kidney. So from the blood from the non-vital to the, it will divert the blood to the vital organ. So this is the reason for the cyanosis. Why cyanosis occurring? The causes for the cyanosis. So the blue indicates the cyanosis. So we answered when and the why. So the next term is the bloaters. Bloater indication indicates the body build of the person. Body build means here you can see the bloaters. They will looks like a overweighted. Otherwise they will have a edema over the limbs and then they will edema over the your feet and ankle and all. They will have a edematous. What is the reason for this one? Means it's because of carpulmonale or the right heart failure. So in chronic condition, there will be an increased pressure in the your bronchus. So that will leads to the increased pressure in the our pulmonary vasculature, that leads to the, that will affect on the right side heart failure, or that will affect on the heart, thereby it will leads to the right side heart failure or carpulmonary. That is the reason for the bloaters. Bloater in the sense the body build of the person. So overall the overweighted person. So it is the reason for the blue one bloaters, blue bloaters. The second condition is emphysema. Emphysema in the sense abnormal permanent enlargement of the distal air spaces that accompanied by the destruction of the wall. Finally that will form the blebs or bullae. So here the main pathology is, consider it is one alveoli and then another alveoli, it's another alveoli. Between the alveoli you will have a interlobular wall. Interlobular wall. So if any destruction in emphysema cases, if destruction happen means what it will form? So it will form the abnormal enlargement. They will merge and then they will form the one unilayer format. So they will merge and then they will form the, it is called the emphysema. It will form the bullae. Bullae means it is a unilayer sac. So easily it is a unilayer sac with a simple force or with a simple cuff or with a simple position change, that will easily broken out and then that will create a pneumothorax. So blebs in the sense that is a unilayer sac, unilayer air sac even with a simple cuff, otherwise even with a simple position change, easily that will broke, and then that will create a pneumothorax, that is called the spontaneous pneumothorax. Those are the things we'll discuss in later part, upcoming part. That is a, just remember, that is a unilayer air sac. So here that it will lead to what will lead. So here we won't have adequate alveoli part. So alveoli mainly take part in the oxygenation, the exchange of gases, and then loading of the oxygen molecule. So that get reduced. And then in second part, emphysema part, tracheobronchial tree becomes so weak and its branches also collapse during exhalation because of the positive pressure. Again, ultimately it leads to the trapping of the air into the alveoli. So two major things. First one is it will interlobular wall get distracted, and then it will form the blebs or bullae. So ultimately it will affect on the oxygenation and then gas exchange part. Second thing, it will leads to the trapping of the air gases. So this is the major pathology that will occurring in the emphysema cases. So why we are calling emphysema as a pink buffers? So pink buffer in the sense, that is a generalized term where we are using, means if the person have a thin body build and then have a increased breathing effort or increased respiratory rate, means there we are calling as a pink buffers. So we'll segregate one by one. Pink indicates the body, that is the color of the nature color of the body. So in last part we told that is a blue bloaters. Blue indicates the cyanosis. So here in bronchitis there will be obstruction in the airway. So the air, otherwise the oxygen can't enter into the lung, otherwise can't enter into the terminal part. There will be obstruction in the pathway. So that is why blue is discoloration occurring. But here in the case of emphysema, there is no block, means there is no obstruction in the pathway. Just simply the air can reach out the alveoli, but the problem in the alveoli, there will be a problem in the oxygenation. So here easily the oxygen can come and approach the alveoli. So but the alveoli, where the gas exchange occurring, that is the area have a problem. So if one part occur, means that oxygen can reach the other part, and then the oxygenation or gas exchange easily will occur. Mainly it will have a effect in the region wise. So if a lower lobe affected, means the lower lobe alveoli only get affected, the remaining part will occur normally. But in the chronic bronchitis, if obstruction occur in any part, means that will affect the diffusely, it will affect the whole part. That is why blue here, that is the pink. Buffer indicates the increased respiratory breathing effort, otherwise respiratory rate. So here we told it will affect the oxygenation. So if it is affect the oxygenation, means what will happen, that generally our body will sense, so that will increase the respiratory rate, otherwise that will increase the respiratory depth or effort, it will increase. So that is the thing. So to prevent the hypoxia or hypoxemia, that is the normal response of the body. So that is the term buffer, in the sense the person will use the person will have the increased respiratory rate, otherwise the person will have the increased respiratory effort. So when the person will have the increased work of breathing, so the increase the signs of the increased work of breathing, means there you can see the pursed lips, and then there you can see the hyperinflated chest, you can see accessory muscle usage, there you can see those are the increased respiratory effort, that is the sign of the buffers. Pink indicates the color of the person. So that is called pink buffers. Those the person have a thin body build, and then those who have a increased work of breathing. And then common assessment wise, we have to assess the barrel chest, tachypnea, barrel chest, again the transverse diameter, anteroposterior diameter, tachypnea we have to assess, and then we have to assess the increased work of breathing. So work of breathing, again we have to assess the our accessory muscle, we have to assess the pursed lip breathing, those are the things. Pursed lip breathing we told. Increased IE ratio, that is also most important. If the normal IE ratio, if the normal human being, that is about 1:2 or 1:3, because but in the case of COPD there will be obstruction in the airway, so the exhalation will take the prolonged time, that will cause the 1:6, almost 1:8. 1 indicates 1 second, 6 indicates the 6 seconds. So it will take the longer time of exhalation ratio. And so next is an abdominal muscle use. Abdominal muscle use means when it will occur. So while the time of exhalation, if the person have a increased respiratory effort, means during the exhalation they will use the abdominal muscles. So how, but here the most important thing, that during exhalation, that pain of the person that will equal to the hundreds of sits up. Hundreds of sits up. 100 times if the person sits up, how much pain the person will carry, like that person, you using the abdominal muscle for prolonged time, they will have this much of pain. So by reading this in Nancy Caroline, I thought to feel that pain. So we just try, that's a simple 100 sits up, no? Like that I tried. But I started with, I crossed 10 sits up and then I crossed 15. Finally, I reached the 20. At 25, fully I get fed up and then I fall down and then I took a rest of 15 or 20 minutes. So with the 25 or 30 sits up with my stamina, I felt that much of pain, means 100 sits up, I can't imagine how horrible that pain is. So the person, that's why the person easily get fatigue and then they are going with an respiratory failure, respiratory arrest, those are the things. So that is the pain that we'll describing. And then jugular venous distension, because of the, already we know, because of the high intrathoracic pressure, the venous stagnant will occur, that is a jugular venous distension. And then diffuse wheezing, these are the common signs in the COPD cases. Management wise, again we are starting with an scene size of initial 10-second assessment, AVPU you have to assess, you have to assess and treat the airway breathing circulation disability exposure. Little things we can do in the pre-hospital scenarios, because it is a chronic condition, we have to take the person in definitive care, we have to step by step we have to manage. But in acute crisis cases, we can do something in field, like we can treat the bronchospasm by the bronchodilator we can give, and then bronchial edema we can go with an anti-inflammatory. Fluids means if the person severely exhausted, otherwise dehydrated stated, means there, if the person is orient with you and then intact gag reflex, means you can give the oral fluid. If not, means you can administer the IV fluids and then we can treat the hypoxia. So these are the some little things we can do in the field. The immediate situation in acute crisis condition, we can manage, these are the condition. So while treating an COPD, either it is a pre-hospital or in-hospital, while treating an COPD, two major entity we have to remember. First one is a hypoxia drive, second one is a autopip. So we'll see one by one. So first is a hypoxic drive. Hypoxic drive is a state in which a person's stimulus to breath comes from the decrease in PaO2 rather than from the normal stimulus and increase in PaCO2. So what they are telling means, thing in the normal healthy individuals. So in normal healthy individuals, if the CO2 level increase in your body, means what will happen? So it will sense by your receptors, like receptor, like a chemoreceptor, those are the things we have in our body. So that will sense by the hypercapnia by the receptor. So these receptor send signals to your breathing center. So breathing center in the sense your medulla oblongata, your pons, there it will send the signal to the breathing center. So the breathing center, they will take the action, like they will increase the respiratory rate, otherwise they will increase the respiratory depth. So thereby it will easily wash out the carbon dioxide. This is the normal physiology. But in the case of COPD, what will happen? So we told hypercapnia and then hypoxia, it is a normal in COPD cases. So here the physiology will alter. How means? So in normal cases, we told CO2 buildup means the respiratory center will sense and then it will increase the rate and depth, thereby it will wash out the carbon dioxide. But in the case of COPD, already the CO2 in higher state. So the body will change its mindset to the other side. So there, if the again the PCO2 buildup also, again if the patient, again the person PCO2 buildup also, the body will think it is a normal condition. So when the body will stimulate the respiration means when there is an hypoxia, when there is an oxygen level goes down, then only the body will sense there will be a problem in somewhere else. So we have to stimulate the respiratory rate, otherwise we have to stimulate the depth of the respiration. That is the important thing. So that is called the hypoxic drive. Normal condition, if CO2 develop means the body will get stimulate to the brain center, sorry, the breathing center will stimulate the respiration. But in the case of COPD, already the person in the hypercapnic state, so it won't react with an hypercapnia, it only react with an hypoxia. The same thing. So with this concept, we have to maintain the oxygen saturation of means SpO2 of 88 to 92 percentage. We should not expect 100 percentage or more than 94 95 percentage. Always we should keep within 88 to 92 percentage. Here we should have an idea of where to whom we have to administer supplemental oxygen, because if you administer oxygen with a person with a hypoxic drive means more oxygen if you are administrating means the person simply will go with an apnea, because there won't be any hypoxia. So your brain will think, your breathing center will think no need of further oxygenation, otherwise no need of further stimulation. So the brain easily that will go to the apnea. That is a one worsen condition if you are administrating more oxygen, high concentration of oxygen in the hypoxic drive cases. So here we should have the idea of where we have to whom we have to administer oxygen. So first thing, the person who have a LTOT means long term oxygen therapy in home itself, they may have a, they were taking the previously they were taking as a such a 1.5 liters of oxygen nasal flux continuously. If they are taking means there you can administer the oxygen while during the time of transport. So we told if the person in hypoxic drive, if you are administering more oxygen means the person will go into the apnea. So before an apnea, suddenly they won't develop like apnea. First, they will their respiratory drive will depress, and then their respiratory rate like slowly it will get into the single digit. If 12 means they will first drive will decrease, and then they will go to the 8 or 7 or 6. The respiratory rate step by step they will reduce. Finally, at last only they will become the apnea. So if you are administering oxygen to the hypoxic drive cases, so if you are noticing any of the things, so the person respiratory drive get decreasing, otherwise the rate slowly get decreasing means there you have to think, and then there you have to stop or reduce the high concentration of oxygen. That is the most important thing. So the other important thing, if the person become apneic because of increased oxygenation, then his or her skin may still appear perfused, means that will appear in pink color only. So you should not assume like it is still the, it is not apnea, it's some other condition like that. You should not assume with an outside skin appearance. That is one important thing. But in the case of early stages, you can ask the person verbally, you can stimulate the person to take the breath. So that is one of the easiest step. We can ask the person, stimulate the breath by the person itself, instead of going with an oxygen administration that will causing some apnea. That is a more worsen condition. No? So simply you can ask the person verbally, you can stimulate the person. If the person become apneic means then provide a artificial ventilation, consider the intubation. So endotracheal intubation is a more worsening condition in COPD. Once if you put a person in ventilator, that is more difficult to wean the person from the ventilator to the NIV to the normal self breathing. So the person, if you put the person in ventilator means completely they will go into the ventilator dependent cases, more specifically in COPD. So that is why they are mentioning. So to decision to intubate a patient with a hypoxic drive is often complex one. Once if you intubated, the patient may have to live what is left or his or her life on the ventilator. So which is encountered to many patients. So based on the person response, we have to clearly explain them. If we put in the ventilator, mainly they will go with the ventilator dependent, that is difficult to weaning. Based on their consent, based on their wishes, we can go for the intubation or whichever thing. Mainly these are the things will happen in the in hospital only, but in pre-hospital also we have to we should know the those are the conditions. And then other entity is an auto PEEP. So we told about the hypoxic drive, it is an auto PEEP. Not everyone should be ventilated the same way. Means when ventilating a person with a severe obstructive disease like a decompensated asthma or COPD cases, we should remember that the person already have a difficulty in exhaling because there will be a pinching of airway, so draping of air, otherwise you have a the interlumen have a narrow lumen, so it will take a prolonged time. We told like a 1:6, 1:8. So this is the 6 second, 8 seconds the person is taking to exhale the air. So he have a difficulty in exhaling. So complete exhalation must be allowed before the next breath is delivered. So if the person is taking 6 seconds means we have to allow until the 6 seconds, then only we have to give the off. So the next inspiration, the next push. So if you are not following that thing means ultimately the pressure inside the thorax will continue to rise. That is called the R2 PIP. So if the pressure inside the thorax will increase means what will happen? So your venous return will goes down. Venous return will goes down, and then if the venous return input is coming means output also reduce, means your stroke volume will goes down. Stroke volume goes down means your cardiac output goes down, so thereby it will leads to the hypotension, hypoperfusion, still more worsen condition. So here the person will get the cardiac arrest, also one of the major important thing in the autopip cases. And then pneumothorax, so we told the blood will form, so a simple cuffing, otherwise if the intrathoracic pressure will increase means that will leads to the pneumothorax, otherwise spontaneous pneumothorax also the person may get developed. So how we can safely ventilate the person? Normally based on ACLS protocol, if the person went into the cardiac arrest means, so one breath over every 5 to 6 seconds. That is the normal protocol where we are having in the ACLS. But in the case of COPD cases, there we have to give the 4 to 6 breaths per minute. So likewise, if you calculate it means, we'll take a 6 breath per minute. So one breath over the 10 seconds. So one breath over the 10 seconds. So likewise you have to give. So in 10 seconds you have to take, if you are taking 1 second for inspiration means you have to allow the patient to exhale the 9 seconds. Otherwise if you are giving 2 or 3 seconds for inhalation means you have to allow the person to exhale some amount of 7 seconds. So here the exhalation, we should have we should give the adequate time for the exhalation. That is the two major things we have to keep in mind: hypoxic drive and then R2P. So I think these are the major conditions we discussed: asthma and then COPD. Mainly we are encountering those two conditions only. So do your best. Shalom.